Hello, my name is Sean McCafferty from Tucson, Arizona. I am a practicing general ophthalmologist at Arizona Eye Consultants. My colleagues, Dr. April Harris, Lisa Lane, and Jason Levine, and I have no financial interest or association disclosures regarding the material in this study. The study was financed and completed independently of any commercial interest. We are discussing the off-label use of topical McCafferty and topical NSAIDs. I am affiliated with the University of Arizona College of Medicine and the College of Optical Sciences. Clinical pseudophakic cystoid macular edema, or PCME, is the most common postoperative complication by far in most practices, at between 1 and 2.5%, depending upon the study or the patient population. It creates a sense of disappointment in an otherwise technically perfect surgery, creating consternation for the patient and consequently the physician. Even though clinical PCME is considered in most cases to be self-limited, it is almost always treated topically and with subtenons injections. No topical NSAID has been approved by the FDA for the prevention of PCME. Interestingly, numerous clinical trials examining NSAIDs for their effect on clinical PCME have been registered but not published. While numerous publications have examined non-clinical PCME using OCT macular volumes and fluorescein angiography, they have demonstrated effective decrease in the incidence of non-clinical PCME. Those published articles examining clinical PCME, which is what truly concerns the general ophthalmologist in his or her practice, have either stated that topical NSAIDs were ineffective, not including the risk factors for PCME, or the study was of insufficient size. Still, the perception by the general ophthalmologist who uses topical NSAIDs is that they prevent clinical PCME. We confirmed this by conducting a survey of 62 cataract surgeons and found that 72% of those surveyed use them primarily to prevent clinical PCME, far more than to reduce inflammation or to decrease postoperative pain. Previous publications examining postoperative use of topical NSAIDs number around 1,000. And we have had more than 20 years of NSAID use off-label to prevent PCME, but we still have no clear indication of its effectiveness. As a general practicing ophthalmologist, our patients often complain of the expense of medications, and none more than the postoperative NSAID. This compels us to examine its effective use for our patients. Since the body of literature was not able to support the use of topical NSAIDs in the prevention of clinical PCME, but it alludes to its effectiveness, we decided to run the study which we expected to find in the literature but could not. It is a simple study requiring a lot of work. A large, prospective, randomized, double-blind, placebo-controlled trial. The relatively low incidence requires about 1,000 patients. Our endpoint was clinical PCME defined by a decrease of 2 or more lines of vision, or symptomatic vision loss, or distortion with CME demonstrable on OCT and fluorescein angiography. What was often missing in most studies which stated NSAIDs were ineffective was the presence of PCME risk factors. Of course, the general ophthalmologist would want to include the risk factors so that it was representative of his or her practice and can help guide treatment. And it needed to be non-industry supported. We stratified the data into those patients with PCME risk factors, including diabetic retinopathy, branch retinal vein occlusion, central retinal vein occlusion, macular holes, epiretinal membranes, topical prostaglandins, macular degeneration, and also those patients without risk factors. We chose a single NSAID to maximize the power of the study, and since the new higher dose once daily use McCafferty 0.3% had similar indications and ocular penetration, we decided to use it. At the conclusion of enrollment over almost 2 years, we analyzed the data and determined that the use of higher dose once daily topical Mcafferty 0.3% does prevent clinical PCME if used in all patients with a high statistical significance. However, the stratification into those with and without risk factors showed no improvement with topical Mcafferty in those without risk factors. Therefore, the only benefit was seen in using topical Mcafferty was in those patients with PCME risk factors. We included an analysis of macular volumes comparing pre-op to 5 weeks post-op. Similar to other studies, we found an increased macular volume post-operatively, but it was not statistically significant comparing Mcafferty to placebo in those patients without risk factors. However, the post-operative macular volume change was significant in those patients with risk factors, again comparing between topical Mcafferty and placebo. This adds to the evidence that risk factors are the primary driver to decrease the incidence of PCME seen with NSAID use. Lastly, we wanted some indication of what the relative risk for PCME was given each of the risk factors to help guide recommended treatment for the general ophthalmologist. By far, the highest risk was PCME in the contralateral eye, at nearly 20 times increased risk. Not surprisingly, diabetic retinopathy was a close second, followed by branch retinal vein occlusion or central retinal vein occlusion. Interestingly, macular holes and epiretinal membranes contain a 5 to 8 times increased risk for PCME. Even more interestingly, topical prostaglandin use for glaucoma was not a significant risk factor. Neither was macular degeneration nor prior retinal detachment repair. In summary, we studied high-dose, once-daily topical Mcafferty only in its effect on PCME. However, given the body of evidence in the literature examining other topical NSAIDs, we believe it is a fair characterization to expect similar results with other medications, and the extrapolation of these results is plausible. The incidence of risk factors in the general ophthalmology practice can range from 10 to 30%. And the use of topical NSAIDs improves PCME outcomes. However, for those without risk factors, post-operative topical NSAIDs do not improve PCME outcomes. Topical NSAIDs may have additional benefits in reducing pain and inflammation, which may indicate their use, but for the primary reason that the general ophthalmologist uses them, it is only effective in an identifiable subset of patients. Following the conclusions of this study, I personally have changed to only using topical NSAIDs in those patients with identifiable risk factors, or in other patients that I think have a low tolerance for pain post-operatively. Thank you. Please contact me if you have any questions.